that seems to work. Okay, thank you. Right, so as we all know, one of the main outcome goals of awake surgery is that we try to preserve quality of life as much as possible. And one way of doing that is through, that would be nice if it continues as well. Yes, language assessment. And its mainly focus in glioma surgery is on spoken language. That wasn't part of the presentation. Let's see if it continues like this. Yes, okay, we'll get there slowly. Yeah, spoken language is the main task that we use actually in awake surgery for glioma treatment. And especially intraoperatively, the focus is mainly on spoken language assessment. However, we have also something like written language, which is the next one. Yes, written language. Written language is less studied. And if we talk about written language, this thing doesn't really seem to reply to what I'm doing. Okay, anyway, it comprises of the processes of spelling and reading, and both of them are actually increasingly crucial in our communication of daily life. A large part of our communication is now text-based because of the use of computers and smartphones and all of that. But if we compare the written language and spoken language, we can actually see that they are both on a functional and on an anatomical level very different. Though at this moment, written language is still very less understudied in awake surgery, but if we do look into the written language deficits, we see that they're actually quite frequent both before and after surgery, even persistently after surgery. Yes, that's the main question that we drew out of this. If we see these deficits, then how can we prevent these deficits from happening? How can we preserve written language in specific? For that, we studied 13 patients okay, there they are. We studied them before and after surgery. They were all came in with presumed low-grade gliomas, but 4 of them actually turned out to be a high-grade glioma after all. Most of them were, yes, I've noticed, but I can't really do anything about it, I think. I'll just continue talking then. Most of them were in the left hemisphere, and they were included in different locations in the brain. The pre- and post-operative assessment comprised of an extensive neuropsychological testing, and including a language testing, of course, both for spoken language and for written language. And intraoperatively, a part of these patients were tested just with spoken language, as we as is the gold standard in awake surgery. So that was for 5 of the patients, and 8 of the patients actually, in addition to spoken language, also were assessed with written language tasks. So either reading and or writing, I have to say. So that was for 8 of the 13 patients. And for written language specifically, we used a specific test. So if we look at the studies that have monitored written language in awake surgery, they're most often using tests that are used from stroke practice. But we know from other studies that I'm getting my laptop here, that may help. No worries. Sorry for the distraction. Almost there. It is a very pretty picture, though. It's nice to look at, but maybe. Do we need to restart? There we are. Thank you so much. Okay, so I was saying, does this work then as well? Yeah. Yes. So for written language, we developed a new test because we wanted to make sure that we test the written language in these patients in a most sensitive way as possible. So not by using the tests that are commonly used for stroke practice, because these may not be sensitive enough to pick up the subtle deficits that we often see in these patients. So for pre- and post-operative assessment, we have a very large, extensive battery, which includes words, non-words, and sentences. And we constructed them in a way to target specific cognitive processes that are known to underlie the processes of reading and spelling. We developed two parallel versions, so one for pre- and post-operative testing, because the testing is often in a very short time window, so we want to make sure that we avoid repetition practice effects there. There's a possibility to stop halfway in each of the tests, and they're all assessed in the same pseudo-randomized order for every patient. For this test, we have a Dutch and an Italian version right now, and they're both controlled for, we have normative data for 50 non-brain damaged individuals for each of them. Intraoperatively, of course, it's not really feasible and desirable, I would say, to do this kind of large batteries. So we have we selected specific stimuli based on the preoperative performance and also on the knowledge, on the neurofunctional knowledge that we have about the relation between the different parts of the brain and functions of reading and spelling. And we used words and non-words to test these patients during surgery. Right, so if we start at the group level, we see that this is the preoperative performance for the reading, doesn't work, the writing and reading, so the written language task on the left and the spoken language task on the right. And if we compare them with the postoperative assessment, we actually see that the performance is relatively stable for all of these tasks. As I said, we assess some of the patients intraoperatively with written language and some without written language. So we want to take these groups apart to look at them in more detail. And we see that for the group here on the left that was assessed with written language in addition to the spoken language during surgery, we see that performance is preserved, so we don't see any difference between pre- and post-operative assessment on both the reading and the writing task. But if we look at the group of patients that were not assessed with reading or writing during surgery, but only with spoken language, we actually see that reading and writing are pretty well preserved too. So this might be hopeful that maybe just administering of spoken language may be able to generalize also to written language preservation. However, we are talking about glioma patients, and we're talking about glioma patients undergoing awake surgery, and that's a highly individualized and targeted approach, as we know. So we want to look at the individual level, what we see if we look at individual patients. So we have the same two groups, the group that was assessed with written language on the bottom, and the group that was assessed only with spoken language during surgery on the top. And we see that on the different lists for words, non-words, and sentences, we see actually quite substantial individual differences. So every line represents an individual patient here from pre to post-operative assessment. And this is for writing, and we see actually the same but less apparent pattern also in reading, that you do see individual differences there. So having these individual differences as a crucial starting point actually to look at this data, we look more specifically into the group of patients that was assessed with written language during surgery. So there were 7 patients that were assessed with reading during surgery, and if we compare the pre- and post-operative performance on reading tasks before and after surgery, we see that reading is preserved, or at least not significantly improves, for all of these 7 patients. In addition, we tested 3 patients with writing during surgery, and also for these patients, we see that writing is not significantly worse after surgery. So writing is also preserved in the patients that you assess with writing. This means that the task-specific preservation, at least in the patients that we show here, seemed to be quite successful. However, I was talking about this generalized preservation before. So, of course, we don't want to test, and we can't test all the specific tasks during surgery. So we need to make a selection for the intraoperative testing. So we wanted to see what happens with the other written language skills if you test only one. So we take reading as an example. These 5 patients were only assessed with reading and not with writing during surgery. And this is the same graph that I showed before, so they will all they have preserved functioning on their reading tasks. But what happens if you test these patients on writing? So patients that were assessed during surgery with reading, this is their writing performance after surgery. And we see out of these 5 patients that 2 patients actually significantly increased, so they got significantly worse after surgery. So although the preservation is promising, it does not seem to be able to be generalized to all functions, at least in these 2 cases, which is for, on a sample of 5, 2 patients is quite a lot, I would say, and definitely worth considering. So if we go back to the main question of how can we preserve written language, we know now that reading and writing may be affected independently from speech after surgery, but also within written language we know that reading and writing may be selectively impaired after surgery. And we also have seen that intra-operative monitoring helps in preserving written language, but probably just task-specifically or mainly task-specifically. So a targeted evaluation and intervention based on functional neuroanatomy may help to preserve a patient's quality of life. And as we heard already before, that should be done by an extensive preoperative evaluation that gives us the possibility to select intraoperative stimuli, intraoperative monitoring with this selective stimuli to monitor the preservation, and postoperatively an assessment again to verify preservation and target rehabilitation if needed. Thank you very much.
Thank you very much, Dr. Van Ierschot, for your patience and for the great